Hello everyone, my name is Professor Blackard. I will be presenting with Professor Park the new clinical decision model for the Advanced Med-Surg Concept Map. Welcome to our presentation. So the objective of this presentation is that by the end of this presentation, the clinical instructor will be able to understand and relate the information to the Advanced Med-Surg student. So why Concept Map in nursing education? Well, Concept Map is an amazing tool that has been used to develop the student's critical thinking skills. It allows the student to really look at the patient as a whole and to help them develop the overall patient's needs. The next generation NCLEX RN exam really requires a nursing student to have a better understanding of the clinical judgment and reasoning for the student to successfully practice as an RN. So to provide a better understanding of this new clinical decision model, we develop a patient scenario that will guide us through the new format. And as you can see here, patient is JP with no known drug allergies, 52-year-old male, full code, and with no DPOA. So here is a screenshot of the first page of the concept map, and we're going to go over each items individually. So here we're going to talk about the chief complaint, and the chief complaint is what did the patient came to the hospital with. We're going to talk about their signs and symptoms and what they're presenting in the ED with, for example. For the admitting diagnoses is what the doctor says the patient has, which is the medical diagnoses. So here is the history of present illness, and it's a story of the patient and what brought them into the hospital. And this is what nurses, what we do, when we give report at the beginning of each shift. These stories does not change, and it helps us to have a better understanding of what brought the patient in, and to help us develop, is the patient doing better, are they doing worse, and including the pertinent information such as blood pressure, vital signs, and lab work, and ultimately is help us to paint a better picture and to have a better understanding of the patients at the beginning of care. So here's the pathophysiology of the admitting diagnoses. And as you know, patients come into the hospital and they oftentimes have multiple medical diagnoses. And here we require for the student to list at least a minimum of 3. And pathophysiology is a deep understanding of the disease process, and not only will the student just describe pneumonia as infection of the lungs, we expect them to describe at more of a deeper level. And this way is that when the student completely understands the content, they can recall this information later in the concept map, and then they can have a better understanding of how this is affecting patient at this current state. So as you can see in this slide, this patient has pneumonia as part of the pathophysiology. Patient was admitted to the hospital with sepsis, pneumonia, and heart failure. So as you guys know, that the admitting diagnoses is a very complex disease for the students to really understand. And for them, the better understanding of the pathophysiology of the disease will help them to develop a better plan of care. So here is the patient's background, and part of patient's background is patient's medical history, and these medical history is what the patient came to the hospital with. They don't change. Patient develop these over time. We want the student to have a clear understanding of what the patient has, along with surgical history. In this case, patient had a cardiac pacemaker insertion. And why is that pertinent to the patient's current medical diagnoses? We wanted students to broaden their understanding a little bit more in depth of the patient's background, along with the importance of knowing the patient's social history. Perhaps whatever their living situation could have contributed to their medical diagnoses.
In this slide, we're going to talk about cultural considerations. Cultural considerations are a very important part of nursing. We need to understand our patients and understand their background, their beliefs, their culture, their language, If the patient speaks a different language, Spanish, Armenian, Japanese, we need to make sure that we find somebody that can speak to them in their language, make sure they understand what is happening to them, that accommodate their culture and their beliefs. We need to ensure that we provide the best care that we care for those patients. The Erickson developmental stage is, we all understand that Erickson created this based on the expectations, what we need to be at some ages in our life. For example, by 35 to 45, you are expected to have a house, be married, have kids, have a job, start being successful in life. And he measured the grade of success. Having those things make you successful, not having them make you feel like you didn't accomplish what you're supposed to have in life. And we need to make a decision which one we are placed on. Something that I always tell my students to think about is disease and how disease affects your happiness and your life. If you have CHF and you cannot breathe and you have trouble walking and you cannot go to the park, you cannot run, you cannot sleep flat in your bed, how that affects your happiness, how that affects your life quality. So it's very important for them to put the disease process into consideration when they're doing this part of the concept map.
So here's the head-to-toe assessment, and it's important for the student to begin evaluating and do the assessment on the patient after they review the patient's labs, pertinent data such as diagnoses, history of present illness, and by understanding the complete assessment of the patient, the student can better come up with, a thorough concept maps and better plan of care. So here is the laboratory data and the diagnostic results for the patient. We asked the students to highlight all of the abnormals. We asked the students to evaluate all of the data pertaining to the patient, right? All of the lab values. And that way they can have a clearer understanding and they can incorporate some of these findings into our concept map. So here's a snapshot of what we included here of the normal values next to the patient's lab values.
In this slide, we give a better explanation about what we want from the students to do regarding their labs. They want to tell us what is the abnormal. In this case, WBCs are abnormals and BMP. We want them to write down what is the admitting value, the current value, and the explanation. What we want from the students is to understand what is WBCs. What is WBCs? WBCs are blood cells that increase when somebody has an infection or can be decreasing when somebody has diseases like cancer. But we want them to understand and then create a relationship with what is happening to the patient right now and why you think this value is elevated. For example, in this case, this patient admitting diagnosis is sepsis, WBCs are elevated, and we understand that when WBCs are elevated, it's because the patient has an infection. And it goes when the procalcitonin and the lactic acid and give you a better understanding what is happening to the patient right now. Same thing when the BMP is related to CHF, and it's always going to be elevated in patients with CHF, but also patients with renal failure, and we want the students to understand the difference.
Here we're going to talk about the medical management and collaborative plan of care for their patient. As you know, that we can't do nursing alone. We need, other team members to help collaboratively come up with the best plan to take care of our patients. It involves, dietitian, social work, physical therapy, case management, pharmacists, and I want the student to explain, how are we going to get the dietitian involved, to have improve patients' better outcomes. Also social work. Is it going to be a safe discharge? What can social work help, to ensure a safe transition for a patient to go home? Pharmacists, the medications that the patient is receiving now, is it the correct dose based on the patient's weight? Is it, going to have an interactions with other medications that the doctor may order? So this is an overall big picture that the student must understand that they have to incorporate other team members in on the plan of care for our patients.
Patient education is an important responsibility of nurses. We need to ensure that we educate the patients and the families at all the times. Inpatient education and discharge education has to be done properly after the evaluation of the patient needs. For example, inpatient education is important to understand when it's appropriate to educate the patient and what we need to educate the patient about. For example, if the patient is intubated, we would not be educating the patient, but the family. Medications, every medication that we give, sometimes the patients are being taking these medications for a long time and they have a knowledge, but we always have to assess and evaluate the knowledge, because maybe what they understand about the medication is not the right way to take the medication. So we need to ensure that we're doing an evaluation and we're educating. Every new medication requires education. Every procedure done in the hospital requires education. Discharge education is very important that the that the patients get educated in every medication that is new to them, and they're going to be taken at home about the side effects and how to take the medication. For example, you take in diuretics. It's very important for them to know that they have to monitor the potassium levels and what is the signs and symptoms of high or low potassium. Also, if they had to do any kind of testing, like when they take Coumadin, they had to check the INR every 2 weeks because it's directly related to the dose. So they need to understand that education has to be planned in time and it has to be done accordingly to the patient's needs. Also, it has to be done in the language of the patient. You cannot educate in English somebody who speaks Armenian or Spanish or any other language, because that is not appropriate.
So here we're going to talk about medications. And this is a list of the medication that our patient is currently taking. Here's a little screenshot of what the concept map shows for the requirement the student has to include in their medication. So here is the medication, and we asked the student to include, the generic name and the trade name, including the dose and the route. The indication is so important that the student understand why is the patient taking this medication. Sometimes, the patient may be taking medication like Neurontin, for example, is an anticonvulsant, but the patient who is a diabetic might be taking Neurontin for their diabetic neuropathy. But the student must understand why is this patient taking this particular medication. Mode of action is another key importance, why the student must understand how the medication is working, to help the patient in regards to the patient's disease process. And understanding that side effect can help the student better understand and develop a better plan of care for the patient. For nursing consideration, this is something we don't want the student to cut and paste from a textbook. We want the student to really write down their understanding of what we as nurses, what should we be considered, right? What should we look out for? For example, if the patient's taking Lasix, patients should be monitoring their vital signs, monitoring their intake and output, monitoring their potassium level. Should we be giving Lasix, in the evening time? No, it would cause, risk for falls. The patients will be getting up out of bed, trying to go to the restroom in the middle of the night. So these are some things that we want the nursing students to consider as part of this concept map in developing, the better plan of care.
Review of systems. This is the part of the concept map where the students are start showing the understanding and the critical thinking of the patient's condition. What they had to do pretty much is use the assessment, the history of present illness, the evidence of the admitting diagnosis, meeting the labs, the diagnostics, the signs and symptoms, and the understanding of pathophysiology of the disease process to explain what is happening to the patient in every single system. We need to understand that when we're talking about the neuro, the cardiac, the pulmonology, the lungs, we cannot take it as a separate pieces because the patient is one as a whole. For example, the patient that we did in this scenario was found unresponsive when a low saturation and low hemoglobin. So I always ask the students how a low saturation can affect your brain, how a low saturation can affect your level of consciousness, how a low hemoglobin can affect your oxygenation to your brain. And to do that, you need to understand that, oxygen is one of the most important things for your brain. Your brain only take care about two things, glucose and oxygen. And when you don't have enough oxygen is when you're going to start seeing changes in mental status in your patient. Also, your hemoglobin is so low, like in this case, for example, your hemoglobin is 6.5. So what is going to happen is the oxygen doesn't have enough hemoglobin. And as you guys know, oxygen attached to hemoglobin. So low hemoglobin equals low oxygen. Therefore, patient will not have enough oxygen in the brain. Therefore, your level of consciousness is going to change, so your mental status is going to change. Not only to become unresponsive, but sometimes patients can become very agitated or showing some changes in mental behavior, and it can be related to the lack of oxygen. Students are not requested to write paragraphs about this, but to have a clear understanding how the labs and the diagnostics and the medical diagnosis, the elevated glucose, can affect your brain function. This is a review of the cardiovascular system. This is actually an example of one of my students, and the reason I choose to present an example is because I want you guys to be able to see how much the students know and how much they can do if they receive the right guidance. So sometimes what the students need is for you to start making connections with them when they're giving you a report in the floor, so they understand how the pathophysiology is related to the admitting diagnosis, to the labs, to the medications. In this case, this patient has a CHF when ejection fraction of 35. And as you guys know, when you have ejection fraction of 35, your heart muscle is very weak. Therefore, your cardiac output is always going to be really low. And when your cardiac output is low, your oxygen going to your brain is going to be diminished. So therefore, the patients can show changes in mental status or fatigue, always complaining of being tired. And in this case, to that, you also can add that the patient has pneumonia. And when you have pneumonia, the alveoli are not doing the job to interchange oxygen and CO2. Therefore, again, the oxygenation is going to be low. That oxygenation low is going to go affect your heart because it's not enough oxygen to allow that muscle that is already weak to work properly. So as you guys can see, all these diseases, the sepsis, the CHF, and the pneumonia is affecting, each one of them is affecting the cardiovascular system. And that's what we want the students to do, to write down in these boxes how all these diseases is going to affect the cardiovascular system. In sepsis, you're going to have vasodilation, which is going to drop your BP, etc., etc., etc. What you really want to do them is to write down all the labs, all the evidence that they have to prove to you that they are able to do the right connections for the right patient. We not want them to copy and paste from the computer. This has to be only from their brain. That means that they read about the pathophysiology, they learn about the pathophysiology, and they apply this new knowledge to this cardiovascular system.
So here is an example of a respiratory system, and we included from one of another students what they wrote down here to describe the patient who is on a ventilator with low saturations. The students, brought in some of the information to tie in what they found clinically upon their assessment, right? We want the students to pull in information such as like ejection fractions for patient with CHF, and then talk about it, that the heart is not pumping enough adequately, therefore the fluid is backing up into the lungs, therefore, the patients can present with crackles upon auscultation, right? If you talk about the patient who suffers from pneumonia, patient might exhibit shortness of breath. We want the student to elaborate a little bit more, right? Talk about why is the patient experiencing this shortness of breath? Maybe it's caused from the stagnant fluids that's been sitting in the lungs due to the infection. Patients not able to move the fluids adequately. You might show, pull in lab values from, ABGs, for example, to prove that the patient has respiratory acidosis, right? Pull in that the pH is low, and so forth. But we want the student to explain also in depth of how does that affect the patient? What do you clinically see that this patient exhibit? They might see that, the respiration is elevated because of the body's trying to compensate, when they're not receiving enough oxygen. And then go a little bit more in depth with, why would the patient with decreased capillary refills, would be as an example for a patient with pneumonia, for example. So again, it's just another a snapshot of how does the student understand the disease process that's affecting the respiratory system.
Here we go. Welcome to
the new clinical decision model.
Differential diagnosis is a big part of the development of critical thinking. The students must understand when the patients arrive to the ED, when the presentations and signs and symptoms of something, it's the job of the doctor and the nurses to figure out what they have. And that's when we use differential diagnosis. To do this, we have to have a great understanding not only the disease process, the signs and symptoms, but also the labs and any diagnostics that need to be done in order to evaluate what the patient has and for the doctor to write down the admitting diagnosis. When the patients come to the ED, they can come with shortness of breath, difficult breathing, chest tightness, congestion, hypoxia, low BP or high BP, and low saturation. And it's a lot of signs and symptoms that can speak about multiple diseases, but the only way that we nurses and the doctors can verify or clarify what the patient has is by writing the appropriate labs and diagnostics that we need as an evidence of the admitting diagnosis. And it's something that the students can work really hard in trying to understand and make the connections. For example, if you have chest pain, then students might understand that the patient needs to get done an EKG. We want to see if the patients have an ST elevation or depression. We need to do troponins to see if the troponins are elevated. Maybe the patient is having a heart attack, or maybe the patient is going to need to go to the stress test to see if it's positive or negative, or to the cath lab. What kind of medications we're giving to this patient if the patient is having actually a heart attack? Or maybe it's not a heart attack, maybe it's just pneumonia, because in pneumonia you're going to have the same shortness of breath, difficult breathing, chest tightness, and hypoxia when a low saturation and sometimes elevated BP or low BP. How we know it's pneumonia? So then the doctor is going to need to include CBC to evaluate the WBCs to see if we have elevation, so it will indicate infection. Also, elevated temperature. You will not have elevated temperature in a MI, but you will have elevated temperature and pneumonia. So that's why we're going to see what is the included and the excluded criteria. Very important for the students to develop their critical thinking.
Here we're going to talk about critical thinking versus clinical reasoning and clinical judgment. And what are the difference between the three? When I think of critical thinking, I think that is essentially what the students are already doing, right? They are analyzing the body system, reviewing the system that they had completed, prior. They were able to gather the information such as patient came in and they has a decreased ejection fraction. They were able to correlate that information to decreased cardiac output, therefore decrease in blood pressure. What does all those information means, right? And with all of those facts, they can come up with a plan. And that leads us into the clinical reasoning. For the metacognitive process, the student needs to come up with a plan of how do they fix the problem, and from, you know, the pathophysiology and their understanding from their critical thinking. And with that, it would lead us to the clinical judgment of what are our actions? How are we going to achieve those outcomes? And then the students is responsible in putting those in the priority order of what their understanding of how they're going to achieve this goal in a timely manner.
Just to clarify, patients when ETOH will have elevated coagulation, usually when they come to the hospital, the INR will be 3 or 4. We want the patients when AFib and Coumadin INR to be 2 to 3, but usually this patient, especially you are an alcoholic, you're not going to be, probably you're not going to be your INR test every 2 weeks, and usually the hemoglobin will be, the INR sometimes will go up to 4. The next topic that we're gonna be talking about is the recognizing cues. This is the next part of the new clinical reasoning, is recognizing cues. And what we've been talking about till now is how we recognize the cues. What are the cues? Cues are things that are telling us that something is wrong, that something is not quite right. If sometimes a patient comes to the hospital with altered mental status, that is a cue. It's telling it, oh, patient has altered mental status. That is not right. That is abnormal. So we have to recognize all the abnormals, because that is what is going to tell us or talk to us about what is happening to this patient. In this slide, we're going to be talking about analyzing cues and prioritize hypotheses. So when we get all this information, like we reviewed before about the cues, we encounter this amazing amount of abnormals. It's a lot of information, it's a lot of data that we got from the evaluation of the patient, the assessment, the labs, the diagnostics. Now what we're gonna try to do is to analyze them, but it's too many of them to analyze and try to figure out what's going on. So the best way to do this is just using what we talked about before about the differential diagnosis, and is use our knowledge of the pathophysiology of diseases to put all these labs and all these abnormals in different categories. So what we did here is we choose sepsis, GI bleed, pulmonary edema, CHF, and diabetes to group all our abnormals. In sepsis, as all you guys know, you will have elevated temperature because of course it's an infection happening. You will have elevated WB6, and this patient has elevated lactic acid, positive blood cultures. He has really low BP, which we are talking about vasodilation. That is what happened in sepsis for a very complex pathophysiology. Saturation is low, urine is positive, and we also add BUN and creatinine abnormal just because in sepsis you're gonna have acute renal failure most of the times and organ failure. GI bleed, what is the cues for us to analyze, and came with the idea the patient has a GI bleed? Well, his hemoglobin is 6.5, which is really low. His and is really red and bright, and the BP is low. Also, we know this patient as a fact is ETOH patients. In ETOH patients, we had 2 problems, and one is that the coagulation is always abnormal most of the times, and also vitamin K is not being produced the right way. So patients tend to bleed more. Also, when you are an alcoholic, remember you can get a lot of GI ulcers for 2 reasons. One, you don't eat as much because you're just drinking, and second, it's a lot of acid in your stomach. pulmonary edema, congestion, CHF, you had the ejection fraction that is low, the high BNP, the chest X-ray is showing cardiomegaly, and the patient has elevated troponins. Diabetes, if you want to go there, your A1C is elevated and your glucose are elevated. So all is the product of us analyzing the cues. All the abnormals that we have, we just group it into different diseases. Now, how we prioritize the hypothesis, we're just trying to figure out, in order for me to save this patient, in order for me to have a really good outcome, for the patient to have an amazing outcome and really improve and get better, what we had to do first. And we have to make that decision, and sometimes that is a decision that is very difficult to make, because we know sometimes it's not as simple as it looks. But in this case, we just say that the patient is likely to have sepsis, likely to have GI bleed, CHF, pulmonary edema, and diabetes. What we say likely, because we're not doctors, we're nurses, but we're still having a lot of knowledge. We know a lot about pathophysiology. We've been trained to understand the labs and the diagnosis. So we can say maybe, we cannot say for sure, but maybe.
So here we're going to talk about the planning and the implementation for our patient's plan of care. On the left-hand side, we listed, all of the possible interventions that we can come up with. But by coming up with these interventions, we want to educate the students on utilizing the SMART goals. And the SMART goals are specific, measurable, attainable, relevance, and time-based. We want to educate the student on using measurable goals, right? And be specific. We want the blood glucose to be less than 140, and you want the patients to achieve this by the end of shift. We want the systolic blood pressure to be greater than 90, MAP greater than 65 within 30 minutes. And when we say that it's realistic goals, is we don't want the student to achieve the blood pressure, systolic greater than 90 by the end of the week, because, that is not relevant for our patient, right? So we want them to use their critical thinking and make sure that it's appropriate for this patient. And when you see on the right-hand side is our action. Now that we put things into priority, we put that we need to fix the patient's blood pressure first. But how do we, attain this goal? How do we achieve this? As well, by administering vasopressors. We're going to provide fluid resuscitators to help increase this blood volume. How about patients achieving potassium of 3.5? How do we assist the patient in achieving this goal? Well, we need to administer supplemental potassium and monitor the electrolytes, right? So same thing, it goes on and on, but we want the students to think of action words, and when to achieve this goal, right? Administer, obtain, transfuse, rather than the traditional textbook where they teach you to assess and to monitor, because with that alone, we cannot achieve the outcome by just observing the patient's clinical presentation. So here's another key important part is the evaluation. We're going to evaluate if, the goal that you had set for the patient, and if the patient was able to achieve that goal. Now, patients might not necessarily be able to achieve all of the goals. We wanted to evaluate if the patient is doing better, doing the same, or doing worse, right? If your patient is doing the same or doing worse, then your goal needs to be adjusted. We need to revisit it and meet with the interdisciplinary team to have a conversation about how we can, come together and help the patient do better, and set different goals, perhaps, that we can achieve. And also another importance is educating the students on how do they evaluate their goals. Is the goal met or not met? And we want them to explain a little bit more in detail. Let's say if it's not met, how are they going to change their interventions to help achieve this goal? For example, the patient's potassium level is 4.2 post the electrolytes and replacement. Is the goal met? Yes, it is. But let's say if it's at a below the level, for example, 3.1. Maybe perhaps instead of administering 60 MEQs of potassium, perhaps we need to increase the amount, and discuss that plan of care with the physician. So this is for us to reevaluate that our decisions on the intervention, is it working or not, right?